Assalamualaikum, dear students. Hope all of you are keeping well, maintaining good health, and keeping in touch with your study. This is a review class actually because we have uh, covered the spectrum of the diseases of gastroenterology at your level. We have already covered it. So today's class is a review class that we have already discussed in your lecture class. But today we'll talk about the diseases of esophagus. So just to recapitulate that we have learned before, to get it back in our memory, that we have learned or we have discussed in our lecture class in earlier period. While talking about the diseases of esophagus, at first we will talk about the functional abnormality. Disease of esophagus may be structural disease like ulcer, malignancy, stricture, polyp, etc. And some are functional abnormality, but the structural abnormality is not there in the beginning of the disease, but the functional abnormality causing symptom of the patient. The commonest one is motility disorder of esophagus, where the normal motility of the esophagus is lost, and the commonest disease uh, presenting with motility disorder is achalasia of cardia. Achalasia of cardia, where there is absence of effective propagative peristalsis, as well as the tonicity of lower esophageal sphincter is raised. The patient will come to you with difficulty in swallowing. So, achalasia of cardia is characterized by hypertonic lower esophageal sphincter. This is the lower esophageal sphincter. It will be hypertonic. Tonicity will be more than normal. So it will not open even when the food particle reaches over there. It will not open. It will keep keep itself in a closed form. So food within the esophagus cannot pass in the stomach. So food will be accumulated over here. A lower esophageal sphincter fails to relax in response to swallowing wave. Normally, while there is a swallowing wave, there is propagative peristaltic wave along the length of the esophagus, and ileus is relaxed in that situation. But here it will not relax. It will maintain its tonic state. So food will remain within the esophagus rather passing to the stomach. There will not be any effective peristaltic wave, and gradually, due to accumulation of lot of fluid within the esophagus, the esophagus will be dilated over periods of months or years. Gradually the esophagus will become dilated. So this is the basic pathology. There is hypertonic lower esophageal sphincter which is unable to relax even in the presence of swallowing wave, and there will be absence of effective peristalsis, and esophagus will gradually become dilated. This is the basic pathology of achalasia of cardia. Then what is the cause lying behind? The causes are there is defective release of nitric oxide by inhibitory neurons. Defective release of nitric oxide by inhibitory neurons. There are some inhibitory neurons over here. They used to release nitric oxide, and so the smooth muscle becomes relaxed and lower esophageal sphincter opens. But here there is defective release of nitric oxide. Number two, there is degeneration of ganglion cells. There are ganglion cells at the lower esophageal sphincter. They are degenerated in achalasia of cardia, and thereby uh, it causes increased tonicity of lower esophageal sphincter. And loss of dorsal vagal nuclei. Dorsal vagal nuclei has role on effective propulsive propagative peristaltic wave, as well as relaxation of lower esophageal sphincter. So as it is lost in the brain stem, it will aid in the trouble of tonicity of lower esophageal sphincter. So these are the causes. Clinical feature: the patient will come to you with the complaint of dysphagia. As the food is unable to pass from the esophagus to the stomach, here you can see food will be stuck over here. So patient will complain of dysphagia. and regurgitation, because food will be accumulated over here. So when the patient will go to bed lying down on his back, the food will come back from the esophagus through the mouth, and it is effortless. Vomiting is in vomiting, it is vomiting is an active process. There is effort, there is contraction of muscle, but in regurgitation the food will come through the mouth without any muscular contraction. This is effortless. So this is regurgitation. Patient will also complain of chest pain due to dilated, there will be muscular spasm into the dilated esophagus. So patient will complain of chest pain due to that muscle spasm. Patient will complain of aspiration. Food particle will come from the esophagus and enter into the trachea or respiratory tract while lying back or sleeping. So patient will complain of choking sensation, and there will be aspiration of food particle from the esophagus into the trachea and lungs. And gradually patient will develop weight loss due to nutritional deficiency. How to diagnose? Diagnosis is from history, and it is a clinical judgment that the patient has got achalasia of cardia. Then you will take the help of some investigations, like you will go for endoscopy of upper GIT. As there is no mucosal lesion, endoscopy will not be able to find any mucosal lesion, but endoscopy is important to rule out other pathology, other differential diagnosis. Suppose a case of carcinoma esophagus can also give rise to dysphagia. A case of benign esophageal stricture, peptic stricture can rise to dysphagia. So you have to exclude those pathology with the help of endoscopy. Then you go for barium swallow X-ray of esophagus. So in barium swallow of esophagus, you will find that there is a smooth tapering at the lower end of esophagus. Smooth tapering at the lower end of esophagus, and it will strongly suggest the presence of achalasia of cardia. The other test is esophageal manometry to see the presence of normal esophageal contraction, or if there is any abnormal esophageal contraction, that can also be detected by esophageal manometry. Management. For management purpose, we give some pharmacological agent like calcium channel blocker and nitrates. Calcium channel blocker nifedipine is a drug of choice over here, because it causes relaxation of the smooth muscle at the lower esophageal sphincter. Then comes endoscopic therapy like balloon dilatation. Here in this picture, you can see the picture of balloon dilatation. A balloon is passed in the lower end of esophagus at lower esophageal stricture. Then it is dilated, causing dilatation of the lumen of the lower esophageal sphincter. This is balloon dilatation. And sometimes botulinum toxin injection is given because it will cause relaxation of the smooth muscle at the lower esophageal sphincter. So these are the endoscopic therapy. In few patients, if repeated endoscopic therapy fails, in that case, surgical myotomy is done. Surgical myotomy, in other name, is Heller's operation. So this is a picture of surgical myotomy where the circular muscle of the lower esophageal sphincter is cut and the fundus of the stomach is wrapped around the lower end of esophagus. So this is surgical myotomy or Heller's operation. So there are three modalities: pharmacological management, endoscopic management, and surgical management. Complications are due to aspiration of food particle from the esophagus into the lungs. So patient will develop aspiration pneumonia, and that aspiration pneumonia, if not treated well, will give rise to lung abscess. Patient will suffer from malnutrition due to lack of nutrition because the food is not going to the stomach. So the patient will not get adequate nutrition. And in long term, the achalasia cardia can even give rise to carcinoma of the esophagus. So these are the uh, four main complications of achalasia of cardia. So next topic that we'll talk about today in about the disease of esophagus is carcinoma of the esophagus. Esophageal carcinoma. Carcinoma of the esophagus are of two types. The one is squamous cell carcinoma, The other one is adenocarcinoma. Squamous cell carcinoma develops in those areas of esophagus which is lined by stratified squamous epithelium, and adenocarcinoma where it is lined by columnar epithelium. So you can see the most of the upper part of the esophagus can give rise to squamous cell carcinoma, and adenocarcinoma can develop at the lower end of the esophagus. Patient will complain of dysphagia as a carcinoma causes luminal narrowing. So the patient will complain of dysphagia. Food bolus may stuck in the esophagus. While taking food, the patient will complain that my food bolus used to stuck in the retrosternal area. And obviously, patient will develop weight loss due to nutritional deficiency. And there will be chest pain or hoarseness of voice, which suggests mediastinal invasion. If the esophageal carcinoma invades the surrounding structure within the mediastinum, then it will give rise to chest pain. And if it invades the larynx, then patient will develop hoarseness of voice. There are some etiological factors why the carcinoma esophagus, specialist squamous cell carcinoma esophagus is developing. The commonest factor is smoking, strongly associated. Smoking, alcohol excess, alcohol if the patient is taking too much alcohol, and chewing betel nuts and tobacco. It is very common in our area in Sylhet. Chewing betel nuts and tobacco is so common, and that is why carcinoma esophagus is also very common in Sylhet in our area. The smoking, alcohol, and chewing betel nuts and tobacco are very strong associative factors with squamous carcinoma. There are some others like it has association with celiac disease, it has association with post-caustic stricture of the esophagus, and also it has got association with tylosis. Tylosis is a familial hyperkeratosis of palms and soles. It is known as tylosis. So these are the etiological factors for the development of squamous cell carcinoma of esophagus. So what are the investigations that will suggest? Will suggest endoscopy of upper GIT with biopsy. This is an endoscopic picture. You can see this is an endoscopic view, and there is a growth over here. You can see here there is a ulceroproliferative lesion with elevated margin, and the margin is also irregular, and there is some luminal narrowing over here. This is a picture of carcinoma esophagus, and we used to take biopsy during endoscopy in such cases for histopathological confirmation. So this is the investigation of choice for the diagnosis of carcinoma esophagus. Next one is barium swallow extra esophagus. If endoscopy is not available in your hospitals, when you will be a doctor, you will be posted in different hospitals. Maybe some may go to remote areas, so you will not get the chance of endoscopy in every hospital. In that case, to reach to the diagnosis, you can at least go for barium swallow extra esophagus, and you might get a irregular filling defect in the esophagus. This is the esophagus with barium swallow, and you can see a irregular filling defect over here. It will suggest the presence of a proliferative growth over here. So this is a case of carcinoma esophagus. In such scenario, then you will refer the patient to a hospital, to a tertiary level hospital for endoscopy and to take biopsy to reach to the tissue diagnosis. So barium swallow X-ray you can use it as a screening X-ray with patients having dysphagia, especially in elderly. Then we go for chest X-ray peer view. Why chest X-ray peer view? Because we want to exclude any secondaries in the lung. If there is carcinoma esophagus, there might be some metastasis to the lung. So we want to exclude secondaries in the lung, as well as we want to exclude if there is any mediastinal lesion compressing over the esophagus, thereby giving rise to dysphagia. So to exclude the mediastinal lesion and to exclude secondaries in the lung, we used to go for chest X-ray. In this picture, you see so many metastatic foci within both lung fields, within both like cannonball appearance. So these are the metastatic foci within the lung field. Then we can also go for CT scan of the chest and abdomen because before any going to the treatment of a carcinoma esophagus, staging is very important. So for the staging purpose, we want to know whether there is any metastasis in the chest or abdomen. So CT scan will give a further detailed information about the metastasis. So we can go for CT scan of the chest. Here you can see some metastatic foci in the chest with the help of CT scan. And CT scan of abdomen will also show some metastasis in the liver. If there is any metastasis in the liver, you can see those things with the help of CT scan of the abdomen. So these are the investigations we used to do to exclude metastasis. Chest X-ray PAView, CT scan of chest, and CT scan of abdomen. Management. If the diagnosis is early without any local invasion or without any metastasis, then our treatment is curative surgery. But if the presentation is late, the patient came to you in a late stage, so there will be local invasion and there will be metastasis. So if the tumor is squamous cell carcinoma, you will suggest for radiotherapy. And if the tumor is a adenocarcinoma, then it is chemosensitive. So our treatment will be chemotherapy. So next topic that we are going to talk about today is gastroesophageal reflux disease. The term itself says that there are some reflux of gastric content within the lower end of esophagus, thereby creating some tissue damage or some symptoms. So this is gastroesophageal reflux disease, and it is the most common disease of digestive tract. It is the most common disease of digestive tract. Here in this picture, you can see this is an endoscopic view of esophagus, and there are some linear ulcers at the lower end of the esophagus. This is a picture of reflux disease. So this is a picture of gastroesophageal reflux disease. GERD is a chronic disorder resulting from the retrograde flow of gastroduodenal contents into the esophagus, causing symptoms or tissue damage or both. So what happens here, our stomach contains food particle mixed with acid and pepsin. Normally, the tonicity of lower esophageal sphincter prevents the gastric contents to pass into the esophagus. But if there is any problem with the tonicity of lower esophageal sphincter, or if there is raised intra-abdominal pressure due to any cause, can give rise to passage of gastric content into the lower esophagus. Thereby, the acid and pepsin that is coming in contact with the mucosa at the lower esophagus will cause erosions and ulceration, and thereby it will cause several symptoms. And this is GERD, or gastroesophageal reflux disease. If you think about the pathogenesis, it results from the imbalance from the defensive factors and aggressive factors. Our body has got some defensive factors as well as some aggressive factors. The defensive factors are the lower esophageal sphincter itself, as it remains closed, so gastric content cannot pass above. Number two, the diaphragmatic crura. We know the diaphragmatic crura from both sides compresses over the lower end of the esophagus, thereby keeping it slit-like, or keeping it helps to keep it closed. So it is a defensive factor. Intra-abdominal location of lower esophageal sphincter. Yes, lower esophageal sphincter, as it is intra-abdominal and there is some intra-abdominal pressure, those pressure will help to remain the lower esophageal sphincter closed. An acute angle of His. We know that there is an acute angle between the lower end of esophagus and the fundus of the stomach. There is an acute angle. So this acute angle of His also helps to prevent reflux of gastric content into the lower end of the esophagus. Another one is esophageal acid clearance with effective peristalsis. As there is peristalsis within the esophagus, if any gastric content enters into the lower end of esophagus, it will be cleared very soon with the help of effective peristalsis. So all these are defensive factors. Aggressive factors are abnormalities of lower esophageal sphincter, like if it is hypotensive, so tonicity is less, or if there is inappropriate relaxation. Because normally when the food particle reaches the lower end of esophagus, it opens, food particle passes into the stomach, then the sphincter again is closed. But if there is inappropriate relaxation, like food is not passing, but there is relaxed lower esophageal sphincter, so food particle from the stomach can get chance to pass into the lower esophagus. So inappropriate relaxation is an aggressive factor. If there is hiatal hernia, if there is a hiatal hernia, it impairs the function of lower esophageal sphincter, and acid from the stomach can pass easily to the lower esophagus. So hiatal hernia is another aggressive factor. Defective esophageal clearance, if there is defective peristalsis, it will uh, make the lower esophageal clearance of acid difficult. So defective esophageal clearance is another cause. There are some gastric factors, like if there is acidity, increased acid formation in the stomach, or if there is delayed gastric emptying, food particle is stagnant within the stomach, so pressure within the stomach is increasing, and in a particular time the food will pass, due to more intra-abdominal pressure, it will go to the lower end of the esophagus. Raised intra-abdominal pressure due to any cause, like in pregnancy or in obesity, there will be raised intra-abdominal pressure, and that in that time food can pass from the stomach into the lower end of esophagus. And there are some dietary environmental factors also, like fatty food, like chocolate, like ice cream, like coffee. All these diet will cause relaxation of lower esophageal sphincter, and thereby it aggravates the symptoms of GERD. So this picture actually it says the same thing that we discussed in our previous slide. Due to obesity, due to fatty food, there will be relaxation of lower esophageal sphincter, or if there is any defective esophageal clearance, or if there is a hiatus hernia over here, if there is delayed gastric emptying time, and if there is increased intra-abdominal pressure, all these will help this acid and pepsin to pass into the lower esophagus. Apart from that, if lower esophageal sphincter loses its tonicity, or if there is inappropriate relaxation, acid and pepsin will pass into the lower esophagus and give rise to GERD, or gastroesophageal reflux disease, which we used to mention that it is the commonest disease that gives rise to symptom in the epigastric region in digestive diseases. Clinical feature. There are some classical reflux symptoms, like there may be heartburn, there may be acid regurgitation. Heartburn, patient will say that I have retrosternal burning sensation. This is known as heartburn. The patient will say that my throat becomes bitter, my mouth becomes bitter. So this is it will suggest acid regurgitation. Some patient will say I have got dysphagia. In advanced stage of GERD, there may be some stricture formation at the lower end of esophagus and give rise to dysphagia. Some will say I have ordinophagia. Ordinophagia is painful swallowing, painful dysphagia. So if there is an ulcer that will give rise pain during swallowing, and this is ordinophagia. Some will say I have water brush. When acid content is passing from the stomach to the lower end of the esophagus, reflexly it increases the salivation of our mouth, and this is known as water brush. If there is any regurgitation, or if there is a food particle, if there is any aspiration of food particle, within the larynx or trachea, the patient will complain of choking sensation. And there may be hiccup, nausea, and vomiting. So these are the classical symptoms of GERD. There are some extraesophageal or atypical symptoms. Atypical signs and symptoms like some will complain of non-cardiac chest pain. Patient will present to you as if he has got chest pain. It mimics angina. But due to reflux-induced esophageal spasm, actually this is due to esophageal spasm, but it mimics angina. You might think that this is a case of myocardial infarction or angina, but actually this is from spasm of esophageal muscle. And due to repeated or chronic irritation of the uh, acid in the larynx or trachea or respiratory tract, patient might suffer from bronchial asthma, chronic cough, recurrent aspiration pneumonia, and etc. And due to repeated irritation of the larynx with the regurgent that is coming from the stomach to the esophagus, the acid that is causing irritation of the larynx can give rise to recurrent laryngitis. It can also, the acid that coming up from the stomach to the mouth cavity can also cause dental erosions. So what are the complications? Esophagitis is a erosion due to erosion of the esophageal mucosa. Patient will develop esophagitis. Then, if not treated, that erosion will progress to ulcer, and the ulcer can bleed, giving rise to hemorrhage. And if the ulcer is deep enough, it can be even perforated ulcer. So perforation is also possible. Starting from esophagitis, then it goes to ulcer formation, then hemorrhage, then perforation. In long term, due to inflammation in the lower part of esophagus for months or years together, there will be fibrosis, and that fibrosis gradually can give rise to esophageal stricture. If there is blood loss or if the patient is unable to eat normally, you will suffer from some nutritional deficiency and it will give rise to anemia. And in long term, GERD can even turn into malignancy. GERD can give rise to esophageal carcinoma. It is the most lethal complication of GERD. So these are the complication of gastroesophageal reflux disease. How to diagnose? In most of the time, if the patient is of a younger age, we used to give empirical treatment because the history is so suggestive. The patient will say that I have got retrosternal chest pain, I have got bitter sensation in my mouth. Uh, these things are more after you taking food. I suffer from heartburn or choking sensation, especially in lying flat. So history are so suggestive. We used to give some drug and keep the patient in follow-up. If there is symptomatic improvement, then this is the diagnosis GERD. I am talking about younger patient. But if the patient is elderly, above 45 years of age, we will not take the risk. We will go for endoscopy because we have to exclude the malignant disease also. So we'll go for endoscopy, and if we get any ulcer, we'll take biopsy to confirm our diagnosis. So this is the endoscopic picture. This is a normal esophagus. You can see that there is healthy, normal esophageal mucosa. But in case of GERD, there is some linear ulcer at the lower end of the esophagus. Sometimes you will get ulcer, sometimes you will get erosion. But this is the picture: linear lesions. So this will suggest reflux disease, GERD. Next investigation is esophageal pH monitoring. It is also possible 24 hours esophageal pH monitoring, and it will suggest about the number of reflux of gastric content into the esophagus. Then comes barium. Barium swallow extra of esophagus. Especially if the patient is complaining of dysphagia, if you want to find out the narrow segment of the esophagus, then you can go for a barium. And here you can see at the lower end of the esophagus, there is a narrowing, a smooth narrowing at the lower end of the esophagus. As it is smooth narrowing, so it is a benign lesion. So it is due to a benign stricture giving due to GERD. Sometimes you will get irregular stricture that will suggest malignancy, but it is a smooth tapering at the lower end of esophagus. So this is a benign stricture due to GERD. Then you can also go for esophageal manometry to see the tonicity of lower esophageal sphincter, because if the lower esophageal sphincter is loose, it can easily give rise to GERD, gastroesophageal reflux disease. So what is the management? Management is lifestyle modification. You have to ask the patient to avoid smoking, to avoid alcohol, to avoid chewing betel nuts and tobacco, as well as ask the patient not to sleep just after taking food because it will increase the regurgitation. Ask the patient to sleep with a thick pillow so the head end of the body is a bit higher than the other part of the body. It will reduce the reflux. Ask the patient to avoid certain foods like fatty food, like chocolate, like coffee, because these things increases the reflux. Then you use some drug like proton pump inhibitor. It will reduce the acid secretion in the stomach, thereby help in healing of the ulcer due to reflux. Give some prokinetic or domperidone. It will increase the uh, peristaltic activity of the esophagus and thereby help in clearance of acid from the esophagus. And you can also give H2 receptor blocker in exchange of proton pump inhibitor, but proton pump inhibitor is the drug of choice rather than H2 receptor blocker because it is more potent in inhibiting acid production. And you have to give a maintenance therapy as well for some patient who used to develop recurrent symptoms due to reflux disease. You have to give a maintenance therapy with proton pump inhibitor to keep the acid production in lower level. Surgery is rarely needed, not always. And if the patient who failed to respond to medical therapy or patient is unwilling to take long-term PPI, or if there is severe symptoms of regurgitation, then you can think for surgery in GERD, and laparoscopic surgery is also possible. It is known as fundoplication or anti-reflux therapy. This is the picture. You can see the lower end of the esophagus is wrapped by the fundus of the stomach, and there is a wrapping of the lower end of esophagus by the fundus of the stomach. It will decrease the gastric contents to pass into the lower end of esophagus, and thereby it will reduce the reflux of gastric content into the esophagus, and thereby it will reduce the symptom and improve or aid in healing of the ulcer that has developed at the lower end. So these are the treatment of reflux disease. This is for today. In our next class, it will also be a review class, and we'll talk about disease of stomach in that class, inshallah. And thank you today to all of you for your patient hearing. Hope to see you again in our next class. So uh, keep healthy, praying for all of you to Almighty Allah so that you remain healthy, remain happy with your family, and please do not forget your books. Always keep in touch with your study. Thank you so much. Thank you, my dear friend, my dear students. Thank you.